Good morning. Thank you all for joining us early on our Friday morning from the AANN. Um, I'm Jay Volpi. I'm going to be discussing update on the guidelines. You can see this disclosure slide here, so I'll leave that up for a moment for you to review, and then we'll get started with the lecture. So as I mentioned, the lecture today is an update on the PFO guidelines from the AAN, that's the American Academy of Neurology, which were published in April of 2020. Just to be clear, this was technically labeled a practice advisory, and I'm Jay Volpe. I'm the director of the Houston Methodist Hospital Comprehensive Stroke Center in Houston, Texas. And to start off with, why was there a guideline update? Why was there a change here? And simply, guidelines are really statements of evidence-based medicine. And when I was doing my evidence-based medicine course and learning about it, we even thought of guidelines as many ways as review articles. They were reviews of the evidence that was out there. But what makes them a little different is that they're very structured reviews, and they go by very strict guidelines on what should be considered evidence and how one categorizes that evidence. So this is what changed, is that the evidence for efficacy for PFO closure changed, and it came from a number of trials, and I'll highlight these three. The first was the RESPECT trial. The RESPECT trial used the Amplatzer device, and it had medical management versus medical management alone. And the RESPECT trial was published in 2013, and in 2013 that was a primary endpoint that was not met, but that there was a trend, a directional trend in favor of the device. And if they looked at a subgroup called the as treated group, there was a benefit. So that was not quite enough in 2013. There wasn't quite enough evidence to change guidelines based on that trend and based on that as treated analysis. But the RESPECT data in 2017 updated their findings with the additional data of 10-year. And at that point, at the 10-year point, the data was significant in favor of the device in that higher rigor, the intention to treat analysis. In that same year, in 2017, the REDUCE trial. This was a different device, the Gore septal occluder with medical management versus antiplatelet therapy. In that study, the primary endpoint was met in favor of the intention to treat analysis in the initial primary endpoint analysis. So that is the highest level of evidence, that intention to treat analysis. Also in 2017, the CLOSE trial, which was a device plus medical management versus antiplatelet versus anticoagulation, a 3-arm study, was published, and it was somewhat different in that it looked at patients with large shunt or atrial septal aneurysm. They also had a primary endpoint that was favorable in favor of device, and the difference there was that the medical managements were a little less clear. So with these 2017 changes, the FDA put out a statement, actually in late 2016 for the Amplatzer occluder, and in May of 2018 for the Gore septal occluder. And they made a statement saying that these devices showed benefit, but they put in an important comment about that. And it's so important, I think, that it informed the guidelines we're going to talk about in a moment. And I am going to actually read a quote from Dr. Zuckerman, who was part of the division that was in the FDA there. And he said, "But as the device labeling clearly states, patients need to be evaluated carefully by a neurologist and cardiologist to rule out other known causes of stroke and to help ensure that PFO closure with the device is likely to assist in reducing the risk of recurrent stroke." So really, from day one of FDA endorsement, we're seeing the statement that you need a heart-brain team, that you need a logical and thoughtful and complete evaluation for the cause of stroke before going to device management. Also, the FDA commented on safety, saying that there was atrial fibrillation and other serious device and procedure-related complications, and that they were similar in both devices, about 3.9 and 4.2%. So with that background of the FDA endorsement and the evidence-based change, the society gets together, the American Academy of Neurology, to look at this guideline and analyze the quality of the data. They are doing this to clarify a proper approach for decision making, really a way of weighing the risks and benefits for, should I close this patient with a device or should I stay with medical management for this patient? To do this, the committee that wrote the guidelines had two clinical questions. And whenever a guideline is formed, there usually is a very precise clinical question asked, and in this case there were two. So the first question was that in patients with a PFO who've had an otherwise cryptogenic ischemic stroke, does percutaneous PFO closure reduce the risk of stroke recurrence compared to medical treatment alone? And the second question, in patients with a PFO who've had a cryptogenic ischemic stroke or TIA, does anticoagulation reduce the risk of recurrent stroke compared to antiplatelet medications? With those questions in mind, the quality of the data was analyzed by the committee. And the data comes from essentially class 2 studies. A class 1 study is a randomized blinded controlled trial, really triple blinded, meaning not only to the patient and the doctor treating the patient, but to a third evaluator. When we're talking about a device study, you really can't blind a patient to whether or not they're getting a device, at least in this context. And so this was a randomized non-blinded studies, which are called class 2 studies, meaning that there's a moderate risk of bias. With that comes different confidence levels of a recommendation. A confidence level means, what is the guideline saying? A level A confidence means you must do this. Our society feels that this is such a strong recommendation that to not do it is out of the standard of care. A level B is a should do, essentially that this is the kind of recommendation that would be expected to improve the health outcome of a patient population. You should do a level B statement. And a level C statement is a may do. This means that judgment is very much at play in a level C statement, that less well-studied populations, less conclusive results. It is a may do. So level A, must do, level B, should do, and level C, may do. And different societies have different ways of communicating their guidelines, so this may be unfamiliar to you if you haven't seen the AAN guidelines in the past. So we'll talk about the guidelines. Instead of going through them one by one, I've put them together in a way that I think is a little bit more digestible for how we actually think about patients, and that's diagnosis and treatment. So I'll make one quick moment that the only level A guideline, which was a level A confidence, was to do a baseline EKG. So you must do a baseline EKG in your stroke workup. That is, I think, very clearly part of every stroke workup and is important in this case for ruling out atrial fibrillation, at least in the initial evaluation. The level B is the should do statements, and this is the guidelines. A significant proportion of the guideline statements are these should do level B confidence level statements, and I'll talk about them regarding diagnosis and then regarding treatment. So what do the guidelines say about diagnosis? They say that a neurologist with expertise in stroke should evaluate the clinical data and the brain imaging for an embolic pattern and exclude atherosclerosis and other higher risk or non-PFO causes such as hypercoagulability from an antiphospholipid syndrome. These statements are summarized in my bullet point here, but really encompass 6 of the should do statements. In other words, the expertise of the evaluation, the importance of excluding, the importance of brain imaging, and excluding hypercoagulability. The other part of diagnosis is a cardiac evaluation. This is also a level B important should do recommendation, which is at least 28 days of rhythm monitoring in an at-risk population for AFib. So how one defines that is still left a little vague, but I think that one would define it based on typical risks for cardiac arrhythmias, such as age, findings on echocardiogram, and findings on that baseline EKG. As part of that cardiac evaluation, a transthoracic echo and transesophageal echo may also be warranted to evaluate for anatomical factors, and that encompasses 3 of the should do level B guidelines. And then getting to the important statement of efficacy here, that in well-selected patients, they should be counseled about the diagnostic uncertainty and the population prevalence of PFO, and that PFO closure probably reduces recurrent stroke in the properly selected patients. I have a case that we'll discuss in a moment that shows how to really apply this third bullet point in your clinical practice. I think it's really the one that boils it down, that after you've applied that expertise, after you've done that workup, how do you decide what is a relevant PFO and what is an incidental PFO? The other level B should do statements regarding treatment are to share the decision making with the patient, to discuss with them the risks and benefits of the device and the medical options. And for those patients in whom anticoagulation is obligated, those patients who've had recurrent venous thromboembolism, the patients who have a known hypercoagulable state that requires anticoagulation, in those patients, the benefit of PFO closure cannot be confirmed or refuted. Why is that? Well, the studies didn't include enough patients that fit that population that required anticoagulation to draw conclusions. So if you have a patient who requires lifelong anticoagulation, it is a neutral state. They don't have confirming or refuting PFO device closure. So moving to the level C, these are the may do, these are the judgment calls, and I'll discuss those for also for diagnosis and then for treatment. And there's really one for diagnosis here, and it's to consider transcranial Doppler with bubble as a screening tool prior to TTE or TEE. And again, I'm a fan of TCD. If you've heard my lectures before, you know I discuss the importance of TCD as a screening tool, and I will illustrate that here in a moment as well. And then the level C may do for treatment is that you may recommend device closure based on the risks and benefits. You may consider a larger shunt as a sign of a higher diagnostic certainty with less diagnostic certainty in patients with small, deep strokes. And that they state that there's an unclear role for atrial septal aneurysm in small shunts. I want to make one clarification on this point, because when I first looked at these guidelines, when I first read through them, it didn't really sink in until I looked at it more, that this is a statement about diagnostic certainty and not a statement about the risk to the patient of shunt size. What they're communicating here is that a patient who has a more obvious shunt more clearly has a PFO, and that in patients who may have a technical issue with their echo or a smaller shunt, or there's a dilemma whether this is a transpulmonary shunt, all these issues may make it harder to be sure you're dealing with a PFO. That's my takeaway from this statement. The other statements for level C, the may do, is that offering PFO closure to patients over 60 is reasonable if they don't have typical risk factors. What are the typical risk factors for atherosclerosis, hypertension, hyperlipidemia, and diabetes? And especially in those patients who are over 60 after AFib evaluation. And then, as somewhat of a mirror image to that recommendation, offering PFO closure to patients under 30, the ones who wouldn't be expected to have atherosclerosis, even if they had risk factors, even if the stroke is a small, deep type. So in other words, those so-called lacunar or small vessel appearing strokes in a young patient may not be small vessel disease. It may actually be a microembolism. So to be aware that if those patients don't otherwise have a reason for having small vessel disease, such as an abundance of risk factors, you should consider them as well. And when it comes to medical management, another neutral statement here about medical options, you can treat medically with antiplatelet or with these novel direct-acting oral anticoagulation or vitamin K agonists in the non-closure patients. So in those patients that you are treating medically, essentially any of your options for antithrombosis are reasonable. So that essentially concludes the summary of the guidelines. And I welcome your questions. I welcome your statements about that. I will pause and editorialize for a moment and tell you a little bit about what I think of these guidelines. And specifically, should anything have been added? I don't think anything should have been subtracted. I think that they did a fine job of including everything that they did. But if there was anything that I would have added to such guidelines, I would have said that although it's not specifically mentioned here, lifelong antiplatelet therapy in patients after device closure is presumed. We really do need to maybe just underline that point, that once a patient has a device closure, all these studies included device plus antiplatelet at the very least. So having that as a lifelong strategy should probably be underlined. And I would also have said a level C statement regarding follow-up imaging, especially in the reduced study. This was part of the protocol, a 2-year follow-up image. And I think that it helps. It helps also in those cases of patients who may not have wanted closure on the front end, and whether it was because of their life or what was going on at the time, and it's been several months since their event, and now they're coming back for further evaluation. Follow-up imaging in those patients is helpful, and it's helpful to exclude other causes and evaluate for silent recurrent ischemia. And the last point just has to do with nomenclature. I think it may be time to drop the term cryptogenic stroke. If we now have a guideline that says that in properly selected patients, this is a cause and a treatable cause, it's really not cryptogenic. We now know that this cause exists. So moving away from that term to the concept of embolic stroke related to PFO. The same way we have embolic stroke related to AFib, we can have embolic stroke related to PFO. And this is rationally a diagnosis that is a subcategory of ESIS. So if you're using ESIS in your terminology, embolic stroke of undetermined source, this would be that patient who comes in on day 1 or day 2, and you see an embolic stroke, but you don't see vessel disease. They're an embolic stroke of undetermined source. Well, they may eventually declare themselves as AFib. They may eventually declare themselves as PFO. So this is a subgroup in my practice of those patients. So I will turn my attention from the guidelines to a case discussion. And in this case, we will take those guidelines and think through how they might apply in the real world. Because when guidelines are written, they have a lot of formality to them. And how that formality applies to a patient is really what matters. So how are we going to take that information and use it? So this is a case that I think illustrates a number of the issues that the guidelines address. So this is a 34-year-old man. He has some chronic pain, some intermittent palpitations, and he came initially in 2017. So this was a patient who presented a few years ago, and he had left arm incoordination. This is his MRI. I hope it's projecting well for all of you. The big blue arrow was added in case it's not. And you can see there's a diffusion-weighted abnormality in the right frontal lobe. And so his left arm incoordination correlates with that small diffusion abnormality. He had an evaluation at that time. His vessels looked good, and he was placed on aspirin. And that was essentially what came of his workup. He did, at that time, have other evaluations with echo, but they did not detect any PFO at that time. So he returned to baseline and was otherwise living his life until July of 2019, so about a year ago. He again woke up, this time having trouble speaking. And EMS arrived, and in our city, I'm in Houston, we have a stroke ambulance, and they were actually able to administer TPA on site. So he received TPA at the ambulance and was transported then to our emergency room. And on arrival, he'd already improved a little bit, and his NIH stroke scale was 4. So this is his MRI on day 1. And again, the diffusion-weighted abnormality is apparent, this time in the left frontal insula. So how do we approach this patient who's now having a second recurrent stroke, a second event in a different vascular territory at a relatively young age? And this is the embolic stroke of undetermined source, or if we must call it cryptogenic stroke evaluation, is to do a stroke workup. And I'm going to illustrate the 3 steps that I consider crucial, and now I think are really validated by the guidelines. And the first is a tissue-based diagnosis. This is addressed by the guidelines 1A, 1B, and 1G, and then the vessel evaluation 1C, and then looking for an embolic source 1D, E, H, F, and K. So those statements are available to you if you want to download the practice advisory, and they're labeled, they're just organized that way. There's nothing about the numbers or letters that suggest any confidence. The level A, B, C is the confidence, not the numbers. So this is his tissue-based diagnosis, looking at the MRI. And bottom line, if the MRI is negative, if you don't see a stroke in a patient who's had an event, it really isn't sufficient evidence for stroke. And at that point, one should proceed to medical management. If the MRI is positive, the question then, is it positive because of small vessel disease? And how do we determine what is small vessel disease versus what is emboli? Every case is a little bit different, but note that an isolated acute infarct of any size, and again, this was highlighted in the guidelines regarding those younger patients in any location without chronic associated ischemia, are at least potentially emboli. So what does it look like when we look at the tissue? I think this is really a case where we move from the diffusion weighted to the flare imaging. So shown on the first image is the diffusion weighted, which we were just discussing, but then I'm going to show you two different flares. Patient A is actually this patient, and you can see his flare is essentially clean. He doesn't have a lot of white matter hyperintensities. He doesn't have an abundance of small vessel disease. Patient B is a different story. Patient B is not the patient we're discussing, but is an example of what small vessel disease looks like. So if you see a patient who has an abundance of white matter changes, that would be someone who you'd be concerned that maybe this infarct is atherosclerotic. So if we're looking at that flare and we're concluding that the patient doesn't have atherosclerosis in their brain, then we're meeting the tissue-based diagnosis. Moving on to the vessel evaluation, this is where we look for those higher risk causes, those stenosis, that vasculitis, all those things. So MRI is important for the tissue, but MRA, CTA, and Doppler are the imaging that one would use to look at vessels. What might you find? Well, again, this is a younger patient population, heterogeneous kinds of conditions. You might find dissection in some. You might find that reversible cerebral vasoconstriction syndrome in some. You might find moya-moya in a rare case. You certainly might find a microangiopathic case in a patient who has low platelets. You might find a vasculitis. And unlike PFO emboli, these kind of conditions often have more of a patchy appearance on imaging, more scattered ischemia than just a single event, which is contrary to what a lot of people think of emboli versus vessel disease. But these are actual cases of each one of those. To give you an example of what I mean by patchy areas of involvement, the first is, and I think my arrow is just a little bit off there, the first one on the right is actually a dissection. So it's a vertebral dissection in the left pica, taking out the posterior inferior cerebellar artery, showing two areas of cerebellar involvement. The second one is a patient who had TTP. So TTP means that these platelets are being consumed in the vasculature and occluding the vasculature. So a lot of little areas looking like little scattered involvement. And then the last one is a vasculitis, a patient who has diffuse disease, poor forward flow, hemodynamic. And so they just look a little different. So one has to look at the heart, one has to look for cardiac causes, but one cannot forget the importance of the vessels that can also cause this appearance. So speaking of cardiac evaluation, when we look at cardiac evaluation, one of the most common questions that comes up is, who do we do a 30-day, or in this case, the guidelines highlight at least 28 days, and who do we go the next step of doing a loop recorder? And what I'm going to show in this slide is two different study populations, because I think it's important to remember where these data come from. So this is the reduced clinical study. This is the PFO closure study. And important to note, these patients were on average age 45. They had relatively few vascular risk factors, and they had, all of them had either stroke or TIA. And then looking at Crystal AF, which was the landmark trial that brought us the loop recorder data, these are older patients. These are 61-year-old patients on average, and you can see their vascular risk factors here are far more abundant. So keep that in mind, and just from a numerical standpoint, knowing that the incidence of atrial fibrillation in patients between the age of 50 and 59 is less than 0.7%. And it's even lower than that in patients who are under age 50. So biomarkers, we talk about biomarkers, we look at the size of the atrium, we look at the the findings on the EKG, but really age is a great biomarker. As a patient gets over 60, they look more like the Crystal AF study. In patients under 50, they look more like the reduce, and those patients between 50 and 60 are somewhere in between. So how long should we do a loop recorder? This patient had frequent palpitations and had a negative telemetry in the hospital. And the guidelines recommend in someone like this in whom you're concerned about a cardiac evaluation, at least 28 days. But if he was older than 60, I would have gone longer duration. So I mentioned earlier that this patient had for earlier testing done that did not detect PFO. And it's important to note the guidelines address this. They discuss shunt detection and in many ways address this kind of scenario. And they talk about different modalities, and we'll go through that in a moment. And they also discuss shunt size specifically as a diagnostic issue. So this patient in 2017 had a TTE done, and at that point there was no bubble study performed. And in TTE in 2019 it was positive, but the bubble study in 2019 reported a late shunt, and that's where this transpulmonary issue came up. Transpulmonary issue means that there's thought to be an AVM, a small fistula in the lungs that's allowing the bubbles to shunt right to left through the lungs and not through a PFO. So are we getting valid data in TTE? Well, sometimes yes and sometimes no. So this is where the transcranial Doppler recommendation comes from. And it's a very simple test, and if you have transcranial Doppler available at your institution, is that you insonate the middle cerebral artery and you inject the same kind of bubbles into a vein and wait. And even if you don't interpret TCD, even if you don't if you've never even seen a TCD before, you can see a smear of white on the screen, and that's how easy it is to detect a positive bubble study on transcranial Doppler, and it's considered positive if what are called hits, or high intensity transient signals, appear within 40 seconds. Transthoracic echo, a common test that's done, is positive if bubbles appear in the left atrium within 3 cardiac cycles, maybe 8, depending on your echocardiographer. And same thing with transesophageal echo, often considered the gold standard. Transesophageal echo requires, of course, a bit of an invasive test going down the esophagus. So what do we know about these modalities? Why was transcranial Doppler highlighted in the guidelines? This is one study in which they looked at patients who had stroke, 82 of which had cryptogenic stroke, and looked at transthoracic echo, transcranial Doppler, and transesophageal echo, trying to detect shunt size and trying to detect whether or not a shunt was present. And what it found is that if we assume that TEE is the gold standard, all those patients who were TEE positive were also positive on TCD. And all the patients who had a negative TCD were negative on TEE, but there were some TCD positives that were TEE negative. So what we see is a very effective screening tool. So in this series, TCD had 100% negative predictive value. You could count on a negative being a true negative, and it had a high positivity rate that was in some cases not confirmed on TEE, possibly because it was too small, possibly because of morphology, or certainly because it could be outside the heart in the lungs. Keep in mind, TCDs are not very expensive and not very invasive, and this is one modality to keep in mind. So what are the guidelines? The guidelines highlight that it's an effective screening tool. It's not a way of knowing the anatomy. You still have to have a TTE and TE for evaluating the anatomy. And it's important, I think, to distinguish between what is diagnosis and what is treatment. So coming back to our patient, he ended up being reported as having a small PFO. Does that mean low risk? So just a quick trial here that looks specifically at this question and found that in fact in patients who had stroke, cryptogenic stroke, in 80 to 85% of the patients, they had a small to medium-sized shunt. So it's not uncommon for a shunt or a PFO to be read as a small shunt. And then when we look at the empiric data, the actual evidence-based data that comes from the two of the large studies, RESPECT and REDUCE, large versus small PFO showed no difference in recurrent stroke rates. The closed trial was unique in that it only included the larger shunts, and this was addressed in the guideline 2B. So moving from size and shunt detection to actually applying that discussion to the patient. You've done the diagnosis, and now you want to talk about whether or not this is an incidental PFO or whether this is a pathological PFO. I would point those of you who haven't seen the ROPE study to review it. The ROPE study is really one of these scores, one of these diagnostic algorithms for looking at risk factors of atherosclerosis like age, hypertension, smoking, and diabetes. Puts these big databases together and allows you to assess your patient in a fairly structured way. And the ROPE index comes from the ROPE study. So you put in this data, and this is an example of what the table looks like from the ROPE index. So the patient's 34 years old. He's going to get 4 points for that. The patient had a cortical infarct on his imaging, so he gets a point for that. He did not have diabetes and he did not have hypertension. So he gets 4, 5, 6, 7 points on the ROPE index. And the higher you are on the ROPE index, the more likely the PFO is pathological and not incidental. So this is the table that once you make the scoring, you can look at it. And this to me is essentially shared expert decision making. So if you have that patient sitting in front of you, you do that ROPE score with them, you show them their ROPE score, and then you show them a table like this. This is a very clear understanding, I think, for them of where they are on the risk profile. So he's a 7, so this patient had a 72% chance that the PFO was attributable, was the cause of the stroke. So another way to look at that is nothing is more likely than the PFO. And this is a 2-year risk for the ROPE index, so 6% 2-year recurrent risk of stroke or TIA, which is fairly similar to what was observed in the medical management arms of the studies. So addressing that guideline 1A, 1I, 2A, 2C, 2E, shared expert decision making. So in conclusion, this patient had a highly likely attributable PFO, a high risk of recurrence. So at that point, the guidelines support PFO device closure for patients in whom the workup is consistent with PFO etiology. That's guideline 1L. And we now have, supporting those guidelines, multiple clinical trials that support a relative risk reduction of over 75%, less risk of stroke, better outcomes in this population. So with that, I'll wrap up my slides. I understand that we have an audience that likes to ask questions. I'm very enthusiastic about answering your questions. So please, by all means, I welcome any comments or questions.
The first question is, with the evidence that AFib is difficult to rule out in less than 90 days of monitoring, why is the guideline criteria 28 days of monitoring? Is this due to suspected risk of reoccurrence?
Let me give you my perspective on what we know of AFib detection. There's 2 ways to look at AFib detection. One is, did it cause the stroke? And the other is, does the stroke put you at risk of AFib? And these are very difficult, controversial topics still in our field right now. So what we know, let's go to that Crystal AF study. Again, these are patients in that study that were predominantly over age 60 who had vascular risk factors. They found a 10% per year linear detection rate of AFib. So you do have to ask yourself, if I'm finding AFib 2 or 3 years out, was that really the cause of the stroke? Probably not. Probably that either AFib and stroke share some risk factors in certain populations and put patients at risk of both, or there may be a brain-heart connection, not a heart-brain connection here, that something about stroke causes patients to be more prone to arrhythmias. That's unknown. We don't know that. But what we do know is that for the patients who are essentially, they're not advanced age, they don't have a dilated left atrium, they don't have signs of Q waves or prior MIs or wall motion abnormalities, but their heart is basically healthy, a basically healthy heart. this is a reasonable approach, is to take a 28-day sample and then to determine from that sample if it's negative. That, in my practice, that's enough. If it isn't negative, if there's signs that something's there, then that may be a reasonable patient to do longer monitoring. But again, I think that it's hard to make population statements about ESIS or embolic stroke of undetermined source, or that those patients are so diverse that we have to make statements about the individuals when we see them. So a sick heart probably does need years of monitoring. A otherwise well heart, I agree with the guidelines that 28 days or a month is very reasonable.
So then what is the longest time a loop recorder can be in?
It depends on the manufacturers. It depends on the battery life. It depends on how much the patient's triggering. So typically it's 2 to 3 years. And that by the way, is, it's a bit of a difficult discussion with patients about putting something in their body and leaving it in for 2 to 3 years. That's maybe going to have to come out after that point. So one discussion we're beginning to have with patients is that maybe wearables are an alternative. So for your patient who does their 28-day monitoring and doesn't want to do an implantable device, whether it's a Fitbit or an Apple Watch or different devices that are out there, a wearable is a in-between. It's not as robust as an implantable loop recorder, but it does give both the patient and provider some reassurance that you're monitoring. And that would last as long as you keep your watch on.
For PFO, do you do TCD first? And if that's positive, then you do the TEE?
Yes, that's the general approach I take. I think that just the way when you think of stroke, patients are coming into the emergency room, they're being hospitalized. So there's a certain amount of stroke pathway, stroke orders that occur. It's pretty uncommon for a patient to go through without getting an echocardiogram. So they are going to get a transthoracic echo. It may or may not be with bubble. And so for patients in whom we suspect PFO, if they've not already had a positive TTE, or if they've had a negative TTE, the next step in those in whom we suspect is a transcranial Doppler with bubble that has that higher negative predictive value. I feel more confident if it's negative, but also if it's positive, then I feel that it's justified to go that extra step in doing the TEE in those patients. TEE may be warranted for other reasons if you have a suspicion that there's an intraventricular clot or something. But for PFO detection, I do not use it on the front end until we have a positive TCD.
How do you get EMS to give TPA without a CT scan?
Oh, they do have a CT scan. That's what the stroke ambulance has. The CT is in the radiology technician is actually in the ambulance with the patient, and one of these mini CT scans, and they're scanned, and it's enough to detect blood or no blood, and a neurologist is either in the ambulance or available by video.
Small shunt and large shunt, these seem like very imprecise terms for 2020. Is there any scoring behind this?
There are at least 3 different scoring systems, and I completely agree with that comment. Why are they imprecise? They're imprecise because what is a transthoracic echo? It's a 2-dimensional rendering, right? So you're taking a probe and you're putting it on the chest wall, and you're getting a 2-dimensional view of the heart, and you're attempting to understand the 3 dimensions by moving the probe in different planes. And so you're viewing it almost like a flashlight in a dark room, trying to make out what's in there. And what else do we have? We have a patient position. We have a patient lying supine for the most part doing these tests. What is PFO? PFO is a 3-dimensional object. It's a 3-dimensional object that's affected by position, by gravity, by Valsalva, by all these factors. So it is a terribly imprecise assessment. And I think that we're beginning to see evolutions in our cardiac MRIs and maybe even cardiac CTs for better defining these 3-dimensional images. They're somewhat of a challenge because there's not a technician helping the patient with those tests, so they're more patient dependent. But come back to us in a few years, and I think these CTs and MRIs will take over a lot of PFO morphology when it comes to it. For simply detecting whether a shunt is there or not, a bubble test remains simple and effective, but morphology is terribly imprecise. And we certainly see people who have a low shunt on one test and a high shunt on another test. So it's not ideal.
What are your thoughts on using long-term anticoagulation in this population?
Yeah, I sort of knew we were going to get that question. That's also hard. If we go by the guidelines, it's neutral. So if in the non-device patients, in the device patients, I think it's a little clearer that once you close a patient with a device, you're giving that patient antiplatelet. Things can happen, things can change, but for the most part, 99% of our device patients are antiplatelet only. The anticoagulation question is difficult because these other studies that were not necessarily PFO studies, but were ESUS, all comers of ESUS, looked at dabigatran, looked at rivaroxaban, and older studies that looked at warfarin. They had directional trends. They had trends that showed maybe reducing the recurrence risk of stroke from about 4% to 3%, maybe 2.5%. So they were all directionally consistent, but none of them met statistical significance. So if you lump them together in a meta-analysis, you see a trend, but you don't see enough that a guideline can endorse that. And I don't know how those studies are going to go in the future. I don't know if there's going to be enthusiasm for redoing those studies. What I will say is that even if we assume those trends are all valid, again, we're looking at a recurrence risk, again, in this population, it's about 4% in medical management, reducing that to somewhere around 3% with anticoagulation. With device, it's closer to 1%. So there is a gradation there in terms of the recommendation I would make in a patient who's properly selected for device gives them a better benefit than the studies suggest for anticoagulation.
How do you determine if a patient over 60 should be closed?
That's also a very tough case. I think that I would say that if there's one pearl, it's the flare. It's the flare sequence on the MRI. If they have the brain of a 40 or 50-year-old and chronologically they're 60 or 70, I treat them based on their brain, not their age. So we see that. We see people who are fortunate that they have high HDLs, low LDLs, that they're fortunate that they've never had any hyperglycemia, they've never had hypertension, and their brains just look fantastic in their 70s. And then they have an embolic stroke and they have a PFO, and they had just been driving and had a DVT. So it's a very good history. So in those patients, I think you do add an extra level of scrutiny. You need careful history taking. You need careful evaluation for other causes. You do need to pay attention to the valves and the heart and other things that can come on with aging. But again, if a patient has a healthy heart, a healthy brain, and they're beyond 60, I consider those patients, just as the guidelines say, as reasonable to close.
That's all the time we have today. Thank you so much, Dr. Volpi.
Great. Thank you all. Have a great conference.